Hello, good morning.
Sir, good morning, sir. Dr. Kumar, sir, good morning.
Good morning, good morning.
Good morning,
Hi,
Chandrasekhar.
Chandrasekhar, Kumar, how are you?
Morning,
Fine,
sir.
sir. How are you,
doing?
sir?
Very good. So, shall we start or we have to wait for some time?
No, I think we can go ahead.
All of us are here only.
Yeah.
So, I thank, the Karnataka Ophthalmic Society for this wonderful opportunity to discuss a topic which concerns everybody. And I think Dr. Elan has labeled it as very rightly how to react and act and when and how. The only thing I would request is, in case everybody agrees, that we start with the reaction infection, then vitrectomy, because cluster endophthalmitis is the most important talk of this. And because we had in the country recently a cluster endoff, so I would like everybody to listen to that, and I would request Dr. D. Chandrasekhar to take it at the end, so that everybody becomes part of this very important exercise, because this is talk of the town. Even today, there is a big article on Muzaffarpur. Yesterday, also there was a big article. So that is very, very significant. So if Kumar and Matthews and Chandrasekhar agree, let's start, because
Yes,
you see, whensoever we operate, everybody expects to deliver. That is the expectation today from all patients. They want to go back to work very fast. But unfortunately, you see, sometimes God is not with us or with the patient. There may be some kind of post-operative issues, which could be minor, which could resolve over a period of time, or there could be serious issues also, like infection. Because I believe when two C's are very important. Whenever there's a cut, any cut, however small a cut may be, even a 30 gauge needle, which we use for giving intraocular injections or anywhere. So some microorganisms, they have the potential to go inside. Whereas in a cluster endophthalmitis, it's a system failure. It's a system failure. Whereas a sporadic kind of infection, it's generally a breach in the day-to-day working of yours. So we should all be wary of this and try to work in the best interest of the patient. Do not take shortcuts. Do not compromise on the quality of solutions. Do not compromise on the sterility part of it. So these are occurrences which not only bother the patient, but the doctor also, because it is his practice which is at stake. So we are going to discuss stepwise. I think Elan has put very nicely that first of all, first day you see a patient after a couple of hours of surgery, if there is an unusual kind of picture, how should one react and how should one act also? So we have with us KS Kumar, as I fondly call him, a very brilliant surgeon and very great thinker also, out of the box thinker always. He always thinks differently than a lot of us do that. So I'll request KS to tell us what is reaction and what is infection, and what should a comprehensive ophthalmologist. You see, KS may do a brilliant job, but what should a comprehensive ophthalmologist do if he faces an unexpected kind of situation on day one? So over to KS. You can start sharing your slides.
Thank you, Dr. Lalit, for those kind words. And on behalf of KOS, I welcome you, as well as Professor Chandrasekhar and Matthew Kurian, and I welcome all the members for viewing this program. I'll start sharing my slides. Are my slides visible, sir?
Yes, sir.
Yes. Please go on. You are audible as well as visible. You can carry on.
Yeah. Now, TAS or endophthalmitis. TAS or endophthalmitis is a perennial diagnostic conundrum. Before we really get going about the topic itself, I would like to draw your attention to this picture. If we hear hoofs, you are commonly right if you think of horses and not zebras, as the saying goes. In other words, the more commonly occurring diagnosis that we make, the more commonly we are likely to be right and not think of exotic things. In fact, sterile endophthalmitis or a reaction is is more of an oxymoron in the setting of a post-operative reaction. For example, to draw more analogies, if you see that the door there is of that kind, the lock broken, you must think that the house has been broken into and not instead think that due to weather changes or due to rusting, the handle might have dropped off. Or in case of an alarm in the cockpit, the pilots almost always think that the situation is grave and take necessary measures, even if it means an unnecessary landing. So that's how our thinking should be. I've just drawn your attention to real life situations so that we think right in the setting of a post-operative increased reaction. So what is toxic anterior segment syndrome or a reaction? It encompasses varying manifestations. Diffuse corneal edema, limbus to limbus is what is mentioned, or an irregularly dilated pupil and fibrin reaction in the anterior chamber. But I must forewarn here that all these manifestations are many times textbook descriptions. We may not be seeing all these classically in any given case. So what causes increased reaction? This Venn diagram tells us varying agents, topical agents that we may be using, or substances that enter into the anterior chamber, or material associated with cleaning and sterilization. All of these could be causing the anterior segment reaction. This is contracting fibrin in a patient with toxic anterior segment syndrome. You see the first photograph on to the left side here, the whole of the anterior chamber is filled with fibrin, and then with time, the fibrin is contracting. This is another case which had a severe reaction with the hypopion, but with treatment, I will tell you about the treatment later on, the contracting fibrin. Now, serial changes in TAS, these are the pictures which tell us about how the anterior segment as well as the posterior segment changes evolve over a period of time as we monitor these patients, the fibrin reaction over the lens breaking up into small debris here. So endophthalmitis is the intraocular occurrence in an appropriate setting of an event that necessitates microbiological evaluation of ocular fluids and prompt institution of antimicrobial therapy or surgery. In other words, it's purulent inflammation of the intraocular fluids that warrants a more energetic and immediate response from our side, and the causes could be microorganisms, bacteria, and fungi. These are some of the clinical signs again. Now, there is a lot of, what shall I say, a mix of the spectrum of changes that can be seen in endophthalmitis, and one merging into another between endophthalmitis and anterior segment reaction. Textbooks describe several things. TAS or the reaction usually occurs early, but this again is not inviolable. We can have reaction setting in much earlier. Pain is thought to be more in endophthalmitis while none in the TAS. Then there is various attributes related to the discharge, the conjunctival reaction. Limbus to limbus edema is highlighted as a feature of reaction. And then again, the fixed dilated pupil and the intraocular pressure being relatively high in the setting of a reaction. But all of these, I would like to stress again and again, these are not inviolable tabular columns that are cast in stone and that we can rely upon with any degree of certainty to make a diagnosis. So whenever there is an increased reaction, look for provocative factors such as a wound leak or a suture abscess if a suture has been put, or the side port which is leaking. Now, potential risk factors for developing endophthalmitis are related to either the preoperative, intraoperative, or postoperative aspects. We are all aware of all of these factors. And I would like to again draw your attention here that in the endophthalmitis vitrectomy study, pain really as a parameter to assess endophthalmitis is fallacious. 25% had no pain and 15% had no hypopion. So if we have endophthalmitis at one end of the spectrum, we have TAS on the other end, and where the route changes to end off and TAS is something which we'll have to gauge based on our clinical sense, based on the case in question, and based on how the disease evolves every 15 minutes. So this is something like a contest where we, in many of these contests, spot the character contest. Initially, only the eyes are shown. We may not be able to identify. Then the middle part of the face is shown, and then the lower part of the face is shown, and then the picture becomes very clear. Similarly, evolving signs in the fundus also are in the anterior segment, and the fundus are also something similar to that. Now, supposing you make a diagnosis of TAS, it's usually treated with intensive topical prednisolone acetate, taking care to shake the suspension very well every half-hourly with cycloplegics and IOP monitoring. Periodic follow-up every 15 minutes on the slit lamp with the indirect ophthalmoscope is very important, on the slit lamp and the indirect ophthalmoscope. What we look for is the anterior chamber reaction, clearing of the cornea, importantly, contracting fibrin. These finer details can only be picked up on a magnified examination on the slit lamp. And of course, the pupil, which is usually very obstinate in the setting of an endophthalmitis, begins to dilate well. So key points are to examine the slit on the slit lamp for subtle changes. As I said, fibrin begins to contract, pupil begins to dilate well. The fundus view gets better with the indirect ophthalmoscope or the fundus camera, and needless to say, the surgeon is beginning to feel a little more relaxed. These are some of the bacterial growth curves associated with endophthalmitis. Coming to management of endophthalmitis itself, which will be highlighted by some of my other speakers, the basic principles remain: the anterior chamber or the vitreous tap and intravitreal injection. This is something which we really need to emphasize. It's not really the realm of the vitreoretinal surgeon to give intravitreal injections. Every ophthalmologist who operates on cataracts must be able to give intravitreal injections. It's important to ensure correct dilutions and the proper dosage, and always good to refer to a chart prior to dilution, irrespective of how good our memory is. If there are any perpetuating factors like a wound leak or the site port, those have to be dealt with. And vitrectomy, the current indications we will be discussing in consultation with Dr. Lalit Verma. Many times an anterior chamber wash, membranectomy, removal of membranes in the anterior chamber, and intravitreal injections themselves suffice in many situations. So these are some of the pictures to tell us what we need to do. Usually when we take a vitreous tap, we usually give a subcorneal injection here, and these are the various culture media that we employ. The technique of doing an anterior chamber tap, a vitreous tap, which is usually done better to avoid traction on the vitreous with a vitreous cutter, where the suction is removed, disengaged, and then we connect to a syringe and manually aspirate. You don't put the infusion on, use a high cut rate and ask the assistant to aspirate, or you can also do an aspiration with a needle, but this is fraught with risks of retinal traction. And this is the diagram onto your bottom right-hand side, which shows the technique of injection intravitreally. The distance from the limbus is to be, you should be sure about the distance from the limbus, and give a valve in a valved manner with the bevel facing anteriorly, and inject drop by drop so that the jet stream effects on the retina are not there. And the bevel should be towards the lens so that toxic effects of the antibiotic on the retina are obviated. These are pictures to show endophthalmitis responding well to intravitreal injections themselves. Another case with severe endophthalmitis that wouldn't respond to intravitreal injections, and then you go in and do a vitrectomy. So why is it important to distinguish between the two? It's important because we may be able to get away with non-invasive therapy in TAS. However, this needs to be monitored very closely. One must be willing to accept and promptly entertain a different view if the situation so demands, as we are monitoring these patients. And if we don't do that, there's a crucial delay in intravitreal therapy if endophthalmitis is treated as TAS, and we may lose the eye. There are some hybrid categories. If there is a PC-REN, prolonged surgery, retained lens matter, then again, there could be increased reaction, but these are also the same situations where endophthalmitis is also more likely. So err on the possibility of endophthalmitis again. Some high-risk eyes with increased reactions, those are some subgroups. There can be delayed onset TAS in P. acne or low-grade fungi. And objective and critical assessment of clinical signs is vital, and we must always be aware of quiet, painless endophthalmitis in many situations. And Murphy's Law is something which we should always be aware. We must respect the situation and make peace with quickness and alacrity. Now, this is a chart which tells us about how we react to any situation that is disconcerting. Initially, there will be denial, then there will be anger, either at the assistant, either at the OT staff, or at the patient himself. Then we kind of bargain mentally, then we go into some kind of a depression, then we accept and start treatment, when in fact, it should be the other way around. It should start from the other end. We should accept that there is a problem here and start with acting with due diligence. These are some points to discuss about the prevention of reactions, standard operating procedures to prevent reactions we should not get used to, our routines, regular health education of all paramedics, and recalibrating our whole system periodically. In endophthalmitis, there should be zero compromise, as Dr. Lalit was referring to, an obsessive compulsive attention to asepsis always, eternal vigil, and zero tolerance to any breach. And as the saying goes, the more we sweat during peace, the more we are alert to things being normal on a day-to-day basis, the less we bleed during war, the less will be the infection as and when the unfortunate situation of an endophthalmitis really does arise. So TAS or endophthalmitis, it causes equal discomfiture to the surgeon and the patient alike. It's very important to be aware that time is vision and we must not lose it or waste it. And we must make every effort to prevent an endophthalmitis from becoming an endophthalmitis for the patient. This is the diagram which will tell us about the current indications for vitrectomy. The old recommendations of the EBS is no longer followed. If there is a good reflex of the fundus, we initiate medical therapy. If there is improvement, then we continue with the medical therapy, close observation. But if with the good reflex, if the good reflex is not seen, then we straight away go ahead. This is the vitrectomy in early vitrectomy, complete and early vitrectomy in endophthalmitis study. This is the algorithm for management of for reaction. So thank you very much. And I am just hoping that one day artificial intelligence may come into the picture and tell us that this is a given case, this is more of reaction and more of not of endophthalmitis or vice versa. Thank you very much.
Thank you, KS, for highlighting the key features. The key words what I learned from your talk was do not delay, err on the side of infection, and equal discomfort here to both. You see, as a surgeon, I agree with you that you see whether it's a task or a reaction, the surgeon next day is equally uncomfortable that why should it happen. So because I think we have around 20 minutes for each this thing, and we will have some discussion here only rather than postponing till the end, which I don't believe, because postponing till the end means not doing discussion at all. So we'll take a couple of questions from amongst the panelists, or maybe I can initiate. So Case, in your wisdom and experience, what is one most important sign or symptom which tells you that you are dealing with TAS or infection? Because as you rightly said, the treatment, the prognosis, everything is different. So when do you think it is definitely infection? And when do you think it is definitely not infection?
That's again a very difficult question to say, but any reaction on the usually endophthalmitis, the commonly associated bacteria, they start by the second, third day onwards. If the reaction is very precipitous and severe on the first postoperative day, then you are probably dealing with a case of reaction, provided there is no corneal infiltration. If the cornea is involved, then that's most commonly, I mean, highly likely that that is a case of endophthalmitis if it is seen on the first postoperative day. But on the other hand, if the cornea is fairly clear and the reaction is quite severe, I would think that this could be a case of reaction, but follow these patients up very closely. You will know the answer in the course of the next 2 to 3 hours in my experience. And if by that time you don't see clearing up of the anterior chamber, the fibrin contracting, the media getting clearer, then we are dealing with endophthalmitis. We should never be in denial, and we should straight away go ahead and start treating it as endophthalmitis.
So let me precisely count. What do you do? Suppose, as soon as normally what we do is, as soon as we start our day, OPD, first of all, we see all our post-operative patients. Okay, before we start the routine OPD. So you see a patient who has an unusual reaction. So what are your 1, 2, 3 steps? What do you start doing immediately?
Now, first of all, I would like to document. I straight away document these things. I take pictures straight away, so that it's very, very important not only to explain.
Because the reason I'm asking, because there is a whole OPD waiting. As soon as we enter, there's a couple of patients, 10, 20 maybe waiting for you to see them.
No.
And here is a patient, now he will the reaction. And patients and relatives are standing beside you, and patient says, Dr. Saab, I can't see much. So what is your immediate reaction? How do you talk?
Yeah, I would be completely divesting myself from that OPD theater or OPD scenario. If there is somebody to take care of that, I would rather delegate the work to them, or completely cut myself off from that OPD and give all attention to this case on hand, take them into confidence and take them into a separate enclosure, get the patient's relatives in also. Don't try to shoo away anybody at that time and try to be harsh. You have to really be very, very courteous, very careful in this kind of a scenario. Explain the details to the patient that there is something which is not expected. And then, as I said, go by the case history. If there is any feature in the case history that suggests or tells you that this could be reaction based on the case on hand, then you start treating them with topical prednisolone acetate drops every 15 minutes and cycloplegics. And if the pressure is high, anti-glaucoma medications as well. No, I don't usually start them on any systemic medications. I watch them myself closely on the slit lamp every 15 minutes. And if the anterior chamber signs are getting better, if the fibrin is tending to shred up and become small globules, and if the cornea is getting better, the media clarity with the indirect is better, then I feel very reassured. And then I will go and attend to the outpatient and tell the assistant to continue the same medications. If at the end of about 2 hours, I would say 2 to 3 hours is what I would give myself. If there is no improvement at all, if it remains status quo, or if it is becoming worse, I would take a turn. I would take the other route as endophthalmitis and treat the patient accordingly.
Okay, Dr. Matthew or DC, anything different would you do? Anything additional? I think he has very nicely pointed out. Anything additional?
A quick question to KSK. Morning, sir. When would you go in for a anterior chamber or a vitreous tap? How long will you delay?
Yeah, at the end
this is very important. You see what Matthew has asked, Kurian, that is it on the same day? Like you said, you will give yourself 2 hours or 3 hours. Is it on the same day? You will go ahead for AC, vitreous tap and UAB?
Yes. Because I have seen that in about, there may be a different point of view here, but by 3 hours, if it is reaction, definite signs of improvement will be there, provided you are giving the appropriate treatment. If you're still living in denial, if you can't take the route, if you don't know which way to go at the end of 3 hours, then that means you are not been thinking appropriately or treating appropriately. That's what I found.
So patient can have two paths. You have asked the patient to start topical steroids, anti-glaucoma medications. I would add cycloplegics along with it. And you see this patient is like very important thing you said, document. Take a picture, write on your case sheet that this patient has, corneal edema or whatever. Because documentation is very, very important ultimately in the court of law also. You see, court of law says that unusual things may happen, but have you taken right steps in your wisdom or not? That is very important. You see, ultimately,
what was not documented was not done is the legal.
Absolutely. Very important line. So, like Dr. Matthews was saying, I agree that you ask the patient to, hold on, talk to the family, sympathize with them, empathize with them, that there's something unusual happen, but heavens are not going to fall. You please cooperate and things may come back to normal. So if at the end of 3-4 hours, pupil dilates and with my indirect, I see glow coming, things are on the positive side and I may intensify this regimen and then ask him to come tomorrow again, or maybe in the evening, I'll see him again. But if not, that means if there is slightest worsening or zero improvement, then I think this sends the tentacle high and you start counseling again that this patient, we can tell that there is an unusual this thing and you need to inject at the place where the infection is.
Can I come in, Lalit? Can I come in just
please.
one point? I would completely agree with what you said. But if the things are better at the end of 3 to 4 hours, endophthalmitis also, can seemingly seem to get better. So I would be a little wary about calling the patient next day. I would again see the patient in the evening. So
that's what I was. In fact, it just slipped. I just said that before I leave for the day, in the evening, I'll see him again. And if it is still better, then I also become bold enough that you can come tomorrow morning again. Because I have to see the glow, the disc, and the macula. And if with the indirect, pupil has become slightly dilated, and then I'm slightly more comfortable. And then before I leave for the day, that is around, say, 6-7 p.m., I'll, reassure him and seek his cooperation and come tomorrow again. So anything you want to add, DC?
Sir, can I give a personal experience on the topic, sir? If I have 5 minutes, or I can talk at the end also. I was going to a nearby center, which is a few kilometers or maybe 80 kilometers away, twice a week to operate for phaco. There were 2 doctors there. The cases will be kept. I see the case, operate. Next day, I go to see the review also. So once there were 20 cases in the theater, I had operated about a few cases, 2 or 3 only. Then the next day morning, the surgeon there called me and said there are reactions about 9 cases out of the 21 cases. So I went earlier. He called early morning because he did the preliminary. We went there and a retinal surgeon I took along, and we saw that there was edema, and in the 9 cases, minimal to little bit of hypopyon, fibrinous membrane, but it was hazy. So there was a dilemma. The B scan did not reveal anything at that point of time. I know sir will agree that initially it may not be anything at all. Yeah. So we put them on steroids. Yes, sir. We gave them strong cycloplegic and everything. Apart from the steroids and the antibiotics more frequently, we documented everything. And then I went back to my Coimbatore. Evening, the doctor saw and said, sir, out of the 9 cases, 6 have become clear. Vision is also coming up. And 2 have got minimal hypopyon fibrinous membrane. So next day I again went, all the 9 except 1 had cleared. So that also became all right in a day. So it was absolutely 100% a case of TAS. After 6 months, a similar 22 cases were done by 3 surgeons. I did last 3 cases. Evening, next day morning, we went and saw this reaction was there. Similar reaction, edema was there, hypopyon was there, and of course the pain was there for both the sets of cases, and fibrinous membrane. Similar method we started with steroid, antibiotic, and subconjunctival also we gave to be on the safe side at that point of time. And evening again, the doctor called and told me, sir, out of there were 12 cases this time. He said 6 are clearer, 7 are better, still hypopyon and there. Next day morning, all the 12 became full-blown cluster endophthalmitis. And it was Pseudomonas. Actually, the steroids is
So what you're trying to say, steroids...
They went on to a big problem, and I had to end with it. Nothing against anybody or any hospital. It was proven that unopened bottles of the ringer lactate which were used had Pseudomonas. Then there was a case, everything. The organization put a case against the company to say that your unopened bottles had Pseudomonas. The company straight away answered, it is not meant for intraocular use. That's all, sir. That was. And of course, in the court, the protocols were in place and everything was there. The people, they were actually, it was yesterday's talk. They put criminal case against them saying wrong surgery performed, loss of one organ, unlawfully kept in the hospital. They were not discharged at all. But again, they came out of it because all the protocols, unless proven by a medical team, a doctor cannot be arrested. So medically, they were found to be correct, and the hospital came out of it, giving compensation. So this is a
so here, DC. You see, DC. What I'm trying to say is, I think Matthew and KSK may agree that you see, very important point was that follow-up same day, morning, evening is important. You can't say I'll see next day because you may miss the bus. You see, in the former scenario, all the patients improved and they were most likely TAS. But in the second case scenario, what you said, again the same place, same team, everything, cluster endophthalmitis. Yes. So you never know. So therefore, I tend to agree with what Matthew and Kumar are saying. Before you leave for the day, see again. You see, because you can't leave and you say, you put these drops, I'll see you tomorrow. Tomorrow, you may, because especially in a Pseudomonas anal, you may lose the eye itself. So it's a very fine overlap sometimes or misbalance, because like KSK was saying, that even Endoph sometimes because all infections have itis also, they may tend to show some plus point. So you don't go by that. You have to rely more on signs rather than the symptoms at this stage.
So the doctor was a senior surgeon. Actually, yesterday I spoke about do's and don'ts. Minimum 3 times the case has to be seen once they are admitted. Better to keep them in admission, sir. So thank you so much.
You see, the reason I wanted 1, 2, 3 was not that whatever we do, because message has to go to the comprehensive ophthalmologist or people who are listening. That you see, I also had a similar episode. You see, I had done silicone oil removal in 3 of the VR surgery operated patients. And believe me, all 3 were very well known. One was a doctor, the other was an advocate, and third, I don't remember. So all 3 patients had hypopyon the day I entered. It was Saturday morning, like KSK said. So all 3, I took them to the top floor and counseled and talked for 1 hour, canceled the entire OPD and gave it to somebody that please take care, and documented, took pictures and managed this patient. What I'm trying to say is isolation is important. Talk to the patient is very important. and then see once, twice, or maybe before you leave, because you have to see that there is a either positive or negative, and you have to decide whether you have to intervene on the same day with intravitreal or you can postpone for the next day. So I think with this
point,
clear,
it is better, like Dr. Kumar said, documentation, photograph, it is easier to tell them there is a reaction and get a signature from them on day 1, not on day 4. They will never accept. So they become a legal document for us also, sir. Thank you so much, sir.
Yeah. Okay, with this, I think we'll move on. Next 10-15 minutes we'll spend on vitrectomy, and then we'll request Dr. Matthew to tell us how to save yourself. I think these points will crop up again at that time. So if you permit, I'll just share my screen here. And let me know if it is visible so that we can start right away.
Yes, sir. Clear, sir. Clear, sir. You can go to slide, sir. Yes.
Yeah. So I will try to omit those points which Case has already said. Yeah. So once again, I thank POSCON for allowing us to do this very important webinar on endophthalmitis. And I'm thankful to all my colleagues and panelists here. So this is what all of us promise, all the anterior segment surgeons promise. This is what disaster can happen. It's very, very serious, can't be taken lightly. It's not with a pinch of salt, it's a lump of salt also will be too less a understatement. So only an operating surgeon, believe me, can realize the stress and the challenge. Because people who don't operate or, they are, let's say, in any case, very must kind of people, it does not matter to them. So if it's a series of cases, you may have to close, like we had a recent cluster in Muzaffarpur. So we'll discuss about that. And then you may have to close the OT, your name, fame, everything at stake at that time. So operating surgeon only can realize all these things. And you become sad. Your family knows why you're sad today, because in the evening, your morale is down. So it can happen in various situations, but we are talking primarily of intraocular surgery. So this, I think, we'll omit because will be covered by this thing. Best is prevention. A lot of things have already been enumerated. Pre-op, you see for all the local sources of infection. Operatively, I think everybody does it, but it's important to maintain logbooks of everything. Because if you don't maintain it, if the team comes and sees there's a lacuna in maintaining logbooks, then again you are on the wrong foot. Then where's the possible suture? Suture is one thing which can prevent. You see, if the wound is construction is very good, then I think possibility of end-off decreases. Intracameral antibiotics also have been proven that they are important role to play. So key issues like KSK said, delay. Delay is dangerous in these patients of so-called reaction or infection, or sometimes an overlap kind of picture is there. And he was showing one very important picture where the surgeon is in a denial phase. You see, that is not good. You see, you should be willing to accept that my case also, because surgeon only knows that what trauma has he caused during surgery. Does he expect a reaction? Did he touch the iris too often? Was there iris prolapse or whatever? So he knows that I have taken a long time this surgery. This may have some important kind of reaction. And you see, it's a disaster. As I said, it's name, fame, everything at stake. If you don't act, if you don't react, if you don't manage things in time, believe me, this can be the end result. And it's something like murder. It's a very painful situation for everybody. And this I will not allude to because KSK has covered very nicely. And very important thing which I learned and re-emphasizing is there could be an overlap. They are not, short signs which I've listed here, but it tilts your diagnosis sometimes here and there. And as DC was trying to say, that B-scan takes time because vitreous opacity clump formation takes time. And if you immediate first day, B-scan may not be relevant from the point of view of diagnosis at all. So I will share two of my patients. This was one patient who had unusual reaction, but fortunately there you can see some glow. And I treated with intense steroids, but monitored. And fortunately, this lady recovered. This was another patient who was referred for urgent kind of vitrectomy because nothing was visible. But what I could see on indirect and documented here on fundus photography is still clump of opacity in the whitish color. With whitish color, I thought this could be lens dropping. This lady already had eventful kind of surgery. So again, treated with steroids, but followed up very, very closely. same day, every day, and fortunately recovered. So follow-up is very, very important in such patients. But your tentacles have also to be on the raised, that any patient who has unusual pain or decreased vision after initial gain, that patient improved, then again he has gone down. Or persistent edema, chemosis, not improving at all. So in such patients, or fundus glow has been obscured, nothing is visible. So then you think of this deadly red infection here and act immediately, as was being discussed. Take him to the theater, do a tap and give antibiotics. Because antibiotics given in time, believe me, are the mainstay of treatment. And very important thing which KSK also highlighted was that everybody, irrespective of retinologist or other, they have to learn this technique of giving intraocular antibiotics, because this is what will make or mar this eye. So therefore, everybody, you see, everybody gives vitreal, this anti-VEGF injections. For antibiotics, they will refer it to vitreous surgery. So it is very important if you want to save the eye, save your name and fame. So please learn this technique, because it saves majority of these eyes. And this, was distributed by AIOS multiple times. And these charts also, courtesy Cipla, we had distributed to all the ophthalmologists. And this you can't memorize, you have to stick it on the operation theater wall. So dilute error has to be avoided. So this was one patient who was a Sadarji, and he had to be given intraocular Vanco and Kefta, but fortunately responded very, very nicely and recovered 6/6 vision at the end of 6 weeks. So what to do if patients do not, recover to intraocular injections, or patient, do not behave the way like this patient behaved. So in such patients, to my thinking, they are cancer vitrectomy. I do not believe in giving multiple repeated intraocular injections, because you see, unless and until the culture sensitivity report is different, I may, or the facility for vitrectomy is not there, I may. Or if I am sitting in a far new corner where vitrectomy is not available, then I may. But generally, if I have all the facility and patient is not responding to injection, then I consider it suitable for vitreous surgery. Because vitreous surgery has a lot of advantages. It will debulk, it will remove a chunk of the infection. It is likened to an IND of an abscess. And then intraocular injections, penetration also becomes higher. So, other thing is severe endophthalmitis. Once you have day 1 florid, or you see something like patient presenting early surgery, or bleb-related infection, they are very, very severe. Or patient has PL plus minus kind of vision. Or on ultrasound exudates the entire vitreous cavity. That means the load of infection is very, very high. Or post-traumatic. Or you are suspecting fungus in a delayed kind of picture, or a chronic recurrent. So these are the indications where vitreous surgery should not be delayed. You see, previously, what we used to do is we will keep giving intravitreal, and then when, cornea becomes hazy, then refer the patient for vitrectomy. So I believe early vitrectomy, patients who are not responding to injections or very severe patients should be a candidate for vitrectomy. And vitrectomy also, you see, because cornea has to be very, very clear, because otherwise you will do a messy job, you will not do a complete job. And what I believe is you always have to have 6 mm cannula and do an initial core vitrectomy. In mild to moderate infection, this may suffice. But in a patient who has very severe infection, how do you say it's very severe? Very severe means that the entire vitreous cavity till the ora serrata and till the surface is full of muck, full of purulent material. And vision is absolutely PL plus minus. So in such kind of situations, not only core vitrectomy, I will go closer to surface retina. I will remove all the exudates from the surface retina, and sometimes even try to, have a gentle suction to remove the hyaloid face also. Obviously, not at the cause of traumatizing the retina too much, because retina is fragile and inflamed. But all these things, and at the end, a lot of times this silicone oil will be required. So I'll share a couple of videos. This was a patient done a long time back. I was hypotenuse. We could not insert the cannula. So what I'm doing is a needle infusion, so as to firm up the globe, so that then we can take this 6 mm cannula. This is the MVR blade being inserted to make the opening wider. And this 6 mm cannula, because the choroid is thickened. If you put a usual cannula, it may not. Then check the cannula. And once the cannula is inside, obviously you can control everything. So this is another patient where I did not insert the 6 mm cannula initially, but I put an AC maintainer This also can be used in a lot of these eyes. You see, because you can immediately see that it is intraocular. And then after you have done this, the second important step in all vitrectomy patients is that clearance of the anterior chamber. Because if you clear the fibrin or the muck over the surface of IOL as well as on the surface of iris, then the visualization in the retina, like we are using a bent needle here, bent to see a needle, and tease away this fibrin from the surface of IOL. You will get an edge somewhere, and you keep teasing this, because once you remove this membrane, then the things will become slightly better. And then you go inside, and then you do a vitrectomy. Had I not teased this membrane, my visualization of intravitreal maneuvers would have been not so clear. So it is very important to do management of the anterior chamber first and then go inside. So this is another patient who has a full-blown picture. You see here what KSK was saying, this wound was ectatic, and this allowed the microorganism to go inside. You can see this large corneal abscess here, and wound is open from here. We know from where the infection has gone inside. So follow the same principle. The trocar cannula is going straight inside, and then you tease away all this exudative or purulent material on the surface, on the pupillary area. And after a long time, we could, because this was quite dense adherent here, so did not come out so easily. In the process, the IOL got mobilized, and then I removed this IOL, and this IOL did not have one of the haptic here, and which indicate that surgery was an eventful kind of surgery. And then in the now aphakic area, pupillary area, now you become bold enough to remove all this muck from here, remove all this exudative material from the surface of pupil, try to sever away all these connections, because from the abscess to the intraocular cavity, because it is here the infection has gone inside, and suture this wound, and then do a proper vitrectomy, do a depression as I'm doing here in the nasal side, try to remove all these exudates retroiridial behind the iris, depress, and best possible way in all the quadrants, and then you get glow, and ultimately this eye could be saved. So this was the patient, corneal abscess, patient with PL vision, 72-year-old lady, and this is the sutures which I had put in surgery. This was early post-operative period. We could get the glow, details were not seen, but persisted with the medical management. And at the end of a couple of weeks, this was the fundus picture which we had documented. This was another patient where multiple injections had been given somewhere, and patient did not, and this patient had grown fungus. So we had already planned that we will remove the IOL in this patient. So therefore made this anti-smile kind of incision here. And we did go ahead with the planned procedure, did a initial core vitrectomy, then entered the anterior chamber and mobilized this IOL with both the hands operating. Mobilization of IOL is very important, and then remove this IOL from the anterior chamber, from this incision. And very important is to remove this bag also. You see the entire bag we could catch hold of and remove this bag, entire bag. The glow already started to improve at this stage. And then went inside, did the complete vitrectomy. It was not a very severe infection on the surface of retina. It was primarily intravitreal, most of it. And this patient ultimately did well. You can see some colonies of fungus there. We did do a depression vitrectomy also in this patient. This was a patient who had an associated trauma with foreign body. You can see we have already done this vitrectomy. So aim should not be to rush towards the foreign body. Just mobilize the foreign body, remove this fibrin around it, manage the rest of the vitrectomy first, because aim should not be to do the foreign body first. Otherwise, you may, lose the tracks because this patient had very severe infection in the periphery also. So then I'm depressing the periphery. You see all this muck. I would not like to leave all this muck in the periphery. So I'm doing a depression kind of vitrectomy in the infratemporal part, in this part, and then do more depression in the inferior part. After I have satisfied that most of the has been removed, enlarge this incision. This will disturb the fluid dynamics, and therefore we want to remove the foreign body near the fag end. So using this rare earth magnet, in this patient. We could have used a forceps also, but forceps gets spoiled with this. Ultimately, with this magnet, we removed, foreign body came out, and then we went inside again and cleaned the cavity. This is the last video. This patient had a corneal abscess and the entire cornea was melted. So help was taken from a corneal colleague who removed this corneal button. Because entire cornea anterior chamber was full of this purulent material. And a very gross kind of surgery is being done to get rid of this infection. And once this corneal melt was removed, button was removed, the corneal surgeon fitted in this temporary keratoprosthesis. And after that, we went inside the vitreous cavity. And fortunately, inside was not so bad. Primarily, it was all in the anterior part. We did the vitrectomy and fundus was very nicely visualized. And then at the end, he put the corneal button back. So these are a couple of more patients which I'll just run through. This was following the same principles of AC clearance and VR surgery. This patient had to inject silicone oil also and remove the IOL also. This was another patient where IOL was removed. So this patient had PR defective vision, recovered finger counting vision till my last follow-up. So this was post-injection. This injection was given in J and K, and patient developed this picture. And fortunately, we could save this eye. And this patient ultimately recovered 6/12 kind of vision, had grown candida on the. So thus to summarize, vitreous surgery may be necessitated in patients, like I had indicated, a couple of indications where infection does not respond, or it's a severe infection, or a fungus, or a P. acne kind of picture, or a severe foreign body. And the key steps are, first and foremost, is a big cannula because choroid is congested, or an AC maintainer, or a needle infusion. So because once you are sure that you are inside the globe, then I think things are under control. And second important is to manage the AC. Put a visco there and remove the membrane of the surface of iris and IOL. And IOL removal, as the case may be, it's not a must in all. And after you have done this, then you go ahead and do a complete vitrectomy with indentation, and IOF removal, as I said, can wait. Then if it is very severe, I do not hesitate to go very near the retina and inject silicone oil at the end of the follow-up. So in very severe patients, silicone oil has an advantage because it compartmentalizes the globe into anterior and posterior. Anterior, you can cover up with the topical therapy, and surface infection of the retina with systemic drugs. So with this kind of approach, what we have tried to showcase here, a lot of these patients you can save, and a lot of them have useful vision also, and this smile can come back not only on the face of patient but also surgeon. Thank you very much for patient listening. So with this, I will stop sharing and invite any question or this thing.
Thank you, Lalit. It was a wonderful
discussion.
It was a wonderful presentation, as usual. With your wonderful presentation, Lalit. Thank you so much for that wonderful presentation.
KSK?
Yeah, thank you very much, Lalit. Are you hearing me?
I can hear you,
can you
sir.
Listen?
I can hear Dr. Lalit. Maybe something at your end.
Sir, you are audible, sir. We can hear you.
And Lalit is not hearing, I think. Lalit,
yes, sir.
Hello.
Lalit's net is a problem there, I think.
DC?
Sir, can you hear us, sir? We can hear you. We can hear you.
Anyway, that was a wonderful presentation by Dr. Lalit with his copious collection of varied variety of cases. Any of the other panelists have any comment? I had one comment to make. Many times when dealing with such cases, there is a tendency to, fall back on used cutters. So this is one situation where you need a very good cutter because we are fighting with our backs to the wall. So we must not withhold from using a brand new cutter in these cases of endophthalmitis and not use a refurbished old one, which may not serve the purpose optimally. That is one thing. And yeah, that's one thing I wanted to make. Dr. Chandrasekhar, do you have it?
Nothing, sir. It was a good talk from an expert. So it was very clear. Yes, sir.
I think I agree. There is hardly anything to add to that. It was exhausting
I
one.
think lost his connection also.
Yeah, I think he may re-log in, I think.
Yes, sir. Yes, sir.
Sir, do we take up Dr. Chandrasekhar's talk now, or can we go ahead with Matthew? Because your talk, Dr. Lalit wanted at the end, so that everybody.
I will take it last, sir. No problem. Dr. Matthew?
Yeah. May I now invite Dr. Matthew to please deliver his talk?
Yeah. Hello? Is it audible now?
Yes, yeah.
So I don't know why I had to rejoin actually. So really sorry for this.
It was a wonderful, exhaustive coverage of the whole spectrum, Lalit. Wonderful. The only point we were making was you should not hesitate from using a brand new cutter and try to make do with a refurbished, reused cutter in these cases. That's one point I just made in your absence.
I agree with that. So I think let's move on because very important talk we have to listen from Dr. Matthew. How to save yourself, because this is a very big issue amongst all ophthalmologists. We have learned about TAS, we have seen some vitrectomy issues, but more important for everybody is how to investigate these patients and how to save your skin, because nobody wants to land up in court of law, because more often than not, doctor is generally not at fault, but the court or the judges and all these people always catch hold of the doctor only. And it is the doctor's name which is on the headline or the institution name which is on the headline, and others get scot-free. So let's request Dr. Matthew Korean to tell us how to save your skin. Yes, Matthew.
Thank you very much, sir, to the members who have created this wonderful talk, and also to Coscon for this opportunity. I will start by saying that I have no financial interest to declare. And for all of us, if we are operating surgeons, sometime or the other, there is a strong possibility that we may be facing a case of endophthalmitis, worse still, a cluster endophthalmitis. And the immediate reaction is to panic. And the attack from the media and the public is huge. And we need to practice this. Just like we do drills for code blue and code red for fire, we need to have this practiced and ready in the event that we face a situation. So the diagnosis, all of us know, is pretty simple. The problem is that it happens so rarely that it is difficult to identify when the cluster has started. So we should be actively monitoring each and every case that happens. A random 1 or 2 cases will happen from time to time for every cataract surgery center. And there will be usually long interim periods where there are no cases. Then 1 to 2 cases happen, and then that is a concern, because we don't know whether to investigate all cases as the first potential case of a cluster, and to look for preventable or recurring cause in these situations. So,
sir, 1 minute, your slide is not running, sir. Your first slide is only there. We are not seeing your slideshow yet.
Now,
it's not on slideshow at all.
You go to slideshow. Yes, sir. Yes.
Okay, 1 second. Let me start sharing once more.
Yeah.
Am I on slideshow now?
Not yet.
Huh?
You're not on slideshow yet.
Okay, let me just go back, open this one, go to slideshow, alternate tab, stop share. Let me share once more. Am I on slide share now?
Yeah,
yes.
You're now on.
Yes, now it's okay. Now it's okay.
Okay. So there are fairly good statistical methods which will help you to avoid complacency and prevent any overkill, like unnecessarily over investigating a single sporadic case. And what I prefer to do in my career has been to look at a moving average over 10,000 surgeries, either directly or extrapolated, depending on the volume of the surgical site. The red flags which I look for are if there is an organism which is common to multiple cases, or if it is an extremely unusual organism. and whether there is a common underlying cause like either staff, surgeon, OT list, instrument or consumable. The UK standards to investigate are greater than 0.04% and greater than 0.08% should be taken extremely seriously. The first duty, obviously, is to minimize patient harm. And what we should all look for is to shut down the OT. But this may not be as easy as we think it is because of operational or logistical issues. And this is where I feel a modular operation theater complex makes it easy, because if one single operation theater is affected, that it's alone can be shut down. What we should all do is to immediately stop bilateral simultaneous cataract surgery and document that current valid SOPs were used and followed. Notification is a must, and we must alert our colleagues. If we are in a large hospital, the hospital infection control team and the management, and create a multidisciplinary team which includes ophthalmologists, nurses, staff, safety officer, microbiology, everybody, because it is beyond the technical competence of a single individual to manage something, investigate something as complex as this one. Documentation, as has been stressed before, is a must, and incident reports must be completed. We need to look back and see whether the consent forms were complete, the OT notes were complete, and the discharge summary specifically mentions when and how to access emergency care for patients. The case dissection, we must in all situations convey to the patient the awareness of when to access emergency care and what are the emergency post-operative danger symptoms. Post-op review, if we identify cases, we must admit them or keep them for a long follow-up per day or very frequent follow-up. And if one case has been identified, all the other individuals with common factors to the index case must be tracked and must be followed up with increased frequency, at least once in 2 to 3 days, even if they are completely asymptomatic. And probably an emergency contact number can be given for them. Patient factors are very less likely in cluster endophthalmitis, and this is fairly well documented, which we as ophthalmologists know. Procedure factors, again, may be less of a critical factor in cluster endophthalmitis, except for use of the antibacterial prophylaxis, use of an intracameral antibiotic at the end of surgery, povidone iodine preoperatively, and if there are any issues with draping technique, this becomes a challenge and can be a factor for clusters. Common exposure. This is most time-consuming thing for us to figure out. And if there is an electronic medical record, this becomes easier because you can have something like an endophthalmitis matrix where all patients that were exposed to the consumables that were used by the index case can be easily tracked. So this is by looking at the batch numbers of all intracameral fluids. That includes your viscoelastic, the irrigating fluid, if any trypan was used, if intracameral anesthetics were used, moxifloxacin was used at the end of surgery, all that needs to be tracked. The IOLs that are used, batch numbers and brand materials, topical drops and other injections that are used can also need to be tracked for batch numbers. And common patients need to be identified and tracked more intensively. Instrument reprocessing. So the CSSD validation must be seen, and every person that was operated using instruments in that particular batch must be tracked and identified. Every person in the same surgical list was exposed to the similar situations with regard to the engineering controls, that is the air, water and surfaces condition would have been similar for all those patients. All these individuals need to be tracked. And in case of consumables, all residual materials need to be isolated and kept for analysis. In case of discarded items, the same batch numbers should be identified and materials from same batch should be sent for analysis. Literature shows that the contamination sources in outbreaks, the commonest one is intraocular fluids, dyes, and OVD. Extraocular fluids have also been implicated in several situations, including, unfortunately, povidone iodine sometimes. Contaminated phaco machine or tubing has been implicated, but fortunately, with the onset of disposable tubings, the incidence of this one has come down to a certain extent. Inadequate ventilation systems, especially in situations where there is a split unit in the air conditioning system, where the air changes per hour is maintained as less than 20, can be a critical component for introducing a contaminated into the OT, which could not be removed because the air changes were low. CSSD breakdowns can have been implicated in the past, but the likelihood is low. Mix-up of instruments from the uncleaned one accidentally coming into the OT as a potentially sterile instrument is a possibility, especially if there is a poor processes maintained in the organization. These are fortunately relatively rare situations. More than one source can be identified in some situations, but unfortunately in up to 20%, no obvious source can be identified, and we have to discuss what to do in those situations. In terms of microbiology, we have to analyze all the samples that are collected, the intraocular tab for common organisms using the routine culture methods. And today it is possible to have more sensitive molecular methods like polymerase chain reaction. And this is important when a large percentage of investigations come as culture negative by the traditional methods. Also, in cases of fungal infections, this is very critical because you get a report much more quickly compared to the traditional fungal culture methods. We need to test all extra and intracameral solutions and the IOL materials, the instrument sets that were used, the phaco tubing, and handpieces that were used. Look back at all our CSSD parameters and see that these were correct, that there was good documentation of the chemical indicators for steam as well as ETO, and that internal and external process indicators were correctly performed, and there was no lapse in the standard operating protocols. One of the things that we can do after a cluster outbreak has been identified is to validate and see whether the heat penetration resistance test or the helix test is good, and that the autoclave is giving us standards which is above the minimum requirements of the ophthal loads that is put into each load. Environmental considerations are critical. Usually a cluster will happen if there is some civil work in or near the OT, where there is a poor condition of cleanliness, clutter, and ergonomics, where there is a poor separation of dirty and clean areas, and we need to reassess these things, or there has been a cause which has changed this thing, like a stagnation of water, sudden in the rainy season, there has been some seepage from the roof, or some dampness through the wall, damp rise in the wall, etc. And if there has been no preventive maintenance of the equipment, we need to reconfirm the ventilation airflow is appropriate and to rule out cross-contamination from any other case that was done in the same day. So criteria for this one, I'm sure Dr. Chandrasekhar will be taking in greater detail. The temperature, relative humidity, and pressure will be monitored daily by the OT staff itself, but air changes per hour, recirculation, and air velocity, etc. have to be done on maybe 6-monthly validation. Every time there is a outbreak, it is a good practice to get the external expert to come in and validate whether the filter is working properly in terms of efficiency, no clogging, and that there is no bypass leakage. And we can even get a robotic instrument to go into the duct and do a video inspection of the duct system to see that it is okay. The air microbiology surveillance is very critical. Settle plate method is most commonly used, but it is limited in that it detects heavy organisms only. Air sampler, which draws air at a rapid 10 cubic feet per minute for 10 minutes onto a culture plate is a better thing, and it must be remote operated to prevent a false positive happening. So you keep the machine inside the operation theater, come outside, close everything, run the AC for 20 minutes, and then from outside you remotely switch on the machine, take the 10-minute sample, and then send it for culture. Water standards are very critical, because the last thing we do before we glove up is to rinse off the surgical hand scrub material from our hand. And if this water is contaminated, then that would be a problem. So we need to do a detailed analysis, which includes the aerobic plate count, the presence of coliforms, and specifically E. coli, which is possible in the water. The surfaces we need to make sure are perfect and that there is no seepage or damp rise. And we need to check whether the SOPs were followed. Routine surface cultures are not indicated, but certainly it is mandatory after a cluster infection has happened, and a huge list from all the walls, from all the instrument tables, microscopes, phaco machine cultures are necessary. We need to review all our SOPs, and specifically maybe a good idea to look for an external third-party expert to come in and give an independent observation of all our practices, handling the patient movement, use of personal protective equipment, the use of instruments and drug handling solutions, etc. Review surgical techniques and see that all the things are happening as is envisaged in the initial plan. Confirm that all the equipment is calibrated and disposables are being correctly disposed. Confirm that single-use instruments are used only once when it is so designated by the organization. Finally, we are often able to find one specific cause, and then we need to address and correct that one. But like I said earlier, there are some situations where we may not be able to get a specific cause, and in that case, we need to review and revise current prophylaxis protocol, improve any pre, intra, or post-operative activities, consider introducing an extra prophylaxis. For example, if you are not using intracameral antibiotics, we should consider starting that at the end of surgery, and consider getting an external review by an expert panel. This is Royal College of Ophthalmology guideline as to how to identify a cluster, what is the notification required, who to alert, what are the immediate measures that need to be taken. And this is basically to consider cessation of all activities, stop bilateral simultaneous surgery, and to follow all the prophylaxis regimes. In terms of investigations, the list is there, what I have just gone through. I also came across this wonderful article in the Indian Journal of Ophthalmology 2018 by Drs. Desai, Bhagat and Parmar. And this lists out what is to be done by the affected hospital, and also lists out what can be done by an external person going in to investigate this cluster. And in the current situation of the Bihar endophthalmitis cluster, it's very important. So thank you very much, and I'm open to questions.
Thanks, Matthew, for that all-encompassing talk. It was really well covered, a nice compendium on endophthalmitis. Would any of the panelists have anything to say?
So I thought, KSK, I thought let's hear DC, because there may be some overlap between DC's talk and Matthew. And because I thought, because this talk may become very relevant, although Matthew has listed virtually everything which, my only issue is that most of us clinicians, they just know how to cut, how to operate. But a lot of these issues are left for admin people, and you see, or the OT technicians. But once in a while, I think all clinicians should make it a habit to go themselves into the ETO room or autoclave room, or they be familiar. Because I myself, honestly speaking, rarely will, I may still go, but a lot of our, fellow colleagues will not. So, And once infection occurs, they're all, then throwing panic button and all these things. So I do not know that, this should become a part of protocol in the training processes, and all these SOPs, what Matthew very nicely listed, and they should be taught to all postgraduates that this is, you need to learn, apart from, cutting, phaco, and all these surgeries and all, they should learn all these techniques. And OT protocols, how to, go about checking the AC ducts, like he was saying, you put a robot there and you can do. Most of us, honestly speaking, do not indulge in all these things. And I will request DC to, share, because we still want to hear his talk, and then we will have
to be very frank, last Monday, I spoke to DNB candidates across the country on modular rotary, sterilization, validation, because it is repeatedly asked now, sir. I will share my slides. I will skip some of them and move. If time permits, I can add a few points on what should be done when there is a departmental investigation. Is my slide visible, sir?
No.
Not yet. We still have 20 minutes. You can easily complete your talk.
Okay, sir?
Yeah, it's visible now. You can enlarge it. Absolutely.
I will go ahead, sir. Greetings to all of you and those people who will be seeing in the future when it is going to be available on the net. Happy to be part of this elite experts, and thank Dr. Ellen Kumaran for this opportunity. My talk is how to prevent cluster endophthalmitis, and it is going to overlap on what Dr. Matthew said on what all you should look for once it happens, so that if there is any problem. So now HAI, hospital-acquired infection, surgical site is a major chunk. In ophthalmology, it is endophthalmitis. And in others, most neglected one is the acute conjunctivitis, where we don't really take much of steps to prevent one from getting another inside the hospital. 1 in 31 patients in the world get a HAI somewhere or other. So with this in background, it is a nightmare to see as Dr. Lalit Paramasa rightly said. And when you see a cluster like this, it's a nightmare of nightmares. An ounce of prevention is worth a pound of cure for endophthalmitis, but I would say an ounce of prevention is worth more than a ton of cure for cluster endoph. These are the amphitheaters. From there, we have moved on. It was an open makeshift OTs. Today, we have come up to the modular OT, though it is not very important, but our protocols have changed. Any surgical site infection is within 30 days, but if you put an implant, it will be taken as 90 days. 5 cases on a single day is called as a cluster, 5 or more, but even consecutive, I can quote any number of examples. If you get endoph consecutively, also it is a cluster. You need to remember even a single case or 2 may be a warning for a cluster to come. So there is nothing that we have to neglect when you see even 1 case. Currently, clusters are occurring even now, not reported. Many are not reported. Some come through the media and we get to know. Much improved protocols we have, definitely. There is no doubt about it. We also identify when things go wrong, good antibiotic and vitrectomy. ESCRS has told that there is a 4 times diminution of endoph after intracameral cefuroxime, and our own intracameral moxifloxacin has reduced by 5 times. Definitely, these are reports from huge number of cases. There are many aspects. I should thank Dr. Lalit for inviting me for this 2008 workshop to initially create the guidelines. It has been modified and there have been so many things. But today, if you take NABS protocols, they are not prescribed by NABS. They are the best practices across. So if we follow that, NABS being under the Ministry of Commerce under Government of India, it will have a legal value. That is one thing. Whether it is a big hospital or a small hospital, we need to take care of ourselves. It can occur anywhere, whether it's a medical college or so on. First and foremost, remember, we should have the license. Even if everything is normal, if you have operated without a license, everything will become wrong. This pollution control board is the second thing, air and environment, along with their biomedical. So these mandatory things will not be, without that, you will not be saved at all, even if you're 100% all right. If you want to prevent endophthalmitis or cluster is the first question that arose when Dr. Ellen told me. See, you can be happy to have only one, but even that I don't want to have, because one can also become many, because some of the protocols we follow are like that. The cluster can be an iatrogenic HAI or an endogenous infection where you have the in-between protocols from one table to another, one instrument to another, same ringer lab test. It can make it a cluster also. It can be sourced from anything from the individual to any instrument to the restroom. Restroom is one of the commonest places where the source of infection. So it can be in the environment, it can be in the consumables, instruments, team, which has been explained nicely by Dr. Matthew. Now I come to zoning. We need to have this 4 zone. The idea is we never cross the sterile and the unsterile. Outside is the protective zone, then the corridors, everything will become the clean zone. Aseptic is the operating room, and then how we used biomedical waste, all those things go. Here you can see the first is your protective zone, clean zone, you have the marking. So this is how we maintain. In the CSSD, you can say the operation theater is the heart of the hospital. CSSD is the heart of the theater. You have there also zoning. This is an unsterile zone, then you have a clean zone and you sterile. You can have a double door autoclave. These things made it 100% more efficient. So as Dr. Matthew said, HEPA filter is good. If you have an HEPA filter with this efficiency, it is perfect. But if you don't have an HEPA filter, never ever allow them to use a window AC, a split AC properly maintained. So these parameters have been dealt in. See, this is one case which we studied when I was in Trichy. An assisting sister had a subclinical infection of Streptococcus dysgalacticae, and it was proven in Italy genetically that was the cause for a series of infections occurring in that operation theater. So even the personnel there have to take care. No longer we use vertical autoclave. These autoclaves, either it is steam autoclave, ETO or plasma. You have to see all these indicators. These are the things which are important. Documentation of these, which has already been explained. You make sure sometimes what happens, they miss the color change and it may go. So this may be the beginning of your dysfunctioning of the autoclave. So this is something which we need to see. This is a bovidic for vacuum. This is all covered by, Such biological indicator is the gold standard. We use stereothermophilus for autoclaves, and low temperatures we use atrophius. This takes about 48 hours at least to find out. Today we have these rapid readers within about 2-3 hours, by the enzymes we can say it is or not. Otherwise, by the time we get the result, the instruments would have got used by them. This is how you see the biology. So these are protocols which should be meticulously followed. Every point of it is very important. If it is not followed well, we will end up in trouble. How frequently? Class 1 is just a process indicator. It will tell we have switched on the autoclave and switched off. Not a proper way it has worked. But it will be there for every set or every bin, everywhere saying expiry. We can use a gun to say, bovidics 5 and 6 are good. Actually, it should be there in every set so that the surgeon, before he operates, he will know this is a properly autoclaved one. It has undergone the process. So as Dr. Lalit rightly said, it is important for every doctor to know he is responsible for the surgeon as a surgeon to the patient. The validity will depend upon the type of sterilization, the packing material, and so on. So this has to be specific and it can be customized as per the hospital. So whenever there is a failure, we need to recall the patients or whatever has been done along with the that batch, and then make sure corrective actions are made. Check the machine also. There is a question how long you must take the swabs and settle plates. According to NABS, NPCB, you must take it at least once in 2 weeks minimum. This is something which is important. All the HIC protocols I'm showing here, whether it is biomedical waste, hand hygiene, excuse me, spill management, everything has to be followed. Each of them can be a source of infection to spread. This is a protocol which all of us have learned wonderfully during COVID time. There is a method of donning and doffing. We took care because we don't want to get infected, and that is how it is happening. I'll be happy if everybody continues this. These consumables, what I want to say, the liquids are the ones which bring the infection. So there is a practice. Every time we bring in a new batch, we take one sample and check for microbiological surveillance. And it should be documented. We should know which batch, what is used for each patient. So early signs itself, we can recall and take care. The batch expiry and traceability. These protocols have been dealt wonderfully. The diabetes status, antibiotic, all this have been dealt nicely. So this intracameral has played a major role in many institutions and is proving to be very useful. Important don'ts: preparing all trolleys beforehand, 1 hour before the surgeon comes. Unsterile person taking a fetal forceps and preparing a trolley. Throwing around soil linen. A wet linen can invite infection within 1 or 2 hours. Discarded swabs on the skin. These are just hygiene and the correct HIC control methods we need. When sterility is doubtful, stop the theater, even if it is going to be huge numbers. Otherwise, compromising on the patient care will be absolutely unwanted. Linen also, soil linen, soaked linen. Crossing over leftover instruments taken to the next surgery also is not a good thing. So what is important? We should know the protocols. We should know what are the processes in between cases, how the cleaning is done. It should be followed till the end of the day. Initially, we are so holy and so clean, but as it goes, this hand becomes like this and goes on like that. That has to be followed. These registers, the log books, are going to be the lifesavers for us. If there is a problem, they will only be. I can tell you one or two things. One particular cluster, the surgeon who came, it was an ophthalmologist, he took consumables for 2 years to see whether the glove was changed for every patient, whether the other liquid, povidone or whatever has been used separately or so these things are evidences. Sir said, not documented, not done. These are very important. Suddenly you go and see one of the Povidix or the thing, the color would not have changed. That means that time itself there has been a warning. Similarly, microbiological. So these are the log books which will be very important for everybody to follow, which is a good documentation for us to internal audit also will help to find out these things. This is something which came up, there was a question that you cannot do more than, that is nothing. For ophthalmology, initially we had a number of 50 per day, but I think even that is removed. I'm sure Dr. Lalit will touch upon that per operating room or per operating day and per surgeon. It is not that it is the protocols and in between cases what we do, whether you can maintain it from beginning to end. So we work. Many of us do that, but unless we review ourselves regularly, whenever there is a near miss, whenever there is an incident on error, if we do the corrective action and preventive action, we can prevent a cluster. We may not be able to prevent one single case of which is endogenous, but a cluster could be 99.9%. If we do it properly, we should be able to. 0% incidence is a dream. Will it become a reality? We are getting close to it, but it should become a reality. 0% post-op as endophthalmitis should never occur. We should take all. Lakhs of surgeries by the hospital, tens of thousands by surgeon. Unfortunately, what happens? We have some compromise at various levels, not necessarily the surgeon. One person who takes it cool and gives a compromised consumable to us, then it is the hospital name and the surgeon's name. So key to success, good practices, it should be universally followed, monitored periodically, near miss and incidents should be taken care. But still, I would like to leave with this question of sharing an apron for many cases, sharing a glove, whether it is eye surgery or any surgery, it is this sharing of anything between cases where are we justified. Ounce of prevention is worth a pound of care. Ounce of prevention for cluster is really something, it can take a lifetime to come out of a cluster endophthalmitis. I think I've covered what I can within the short period. Thank you so much, sir, once again.
So thanks a lot, DC, for covering in a very short time all the essential steps. I don't think so you have missed any component of...
I'd like to add a couple of points, sir. When there is a departmental investigation on a cluster, there will be 7 to 8 departments that will come. The DBCS, the state blindness control, human rights also come as government. Then the drug inspector will come. Then you have the people, local police will come. So all this documentation cannot be changed further. It should be documented as and when as a routine. And only these are going to prove. And definitely there is a Supreme Court ruling. They cannot arrest and they have to be proved medically only. But if a documentation is not good, and even if we say we did intravitreal, we did without proper documentation, then we will be in a trouble. So it is to prove ourselves that we are not negligent. That is the idea. It will come. Today, as everybody, the crores it runs into, and if we have 50 cases of crores, they have to go, nothing can be done. So Dr. Lalit sir knows, we have seen some incidents and there where it has run for even 12 years for a long period. So we have to make sure, give importance to every patient, not a paying or free or anything. For that patient, that eye is important. That's what I would like to say.
So the number of surgeries, what you were saying was, although the fresh guidelines which AIS had given, so consensus based, it was 30. We had punched at 30. 30, yeah. But I agree. You see, I know of one system like Arvind Eye Care system, but the difference there and this Muzaffarpur was the protocols. The protocols were followed or not, and how to save your, brethren. The thing is, sometimes you know that my colleague is at fault. You see, like operation theater has not been checked, or all these things what you are saying. So it's very difficult to protect these things. But I would agree. You see, if all of us, you see, time is not with us. But only thing would be that we as clinicians, we as surgeons, and we people are responsible for training our postgraduates and doing a regular drill. Like Matthew was saying, something like code blue, we should be regularly be aware of all these things, and not then only we'll not panic. Otherwise, we are not used to. Once a case occurs, and once a while we tend to forget all these very important things which both Matthew and DC have listed here. So Kumar, any other point you want to make, because there are only 1 or 2 minutes left here?
Yeah, nothing much. I think we should make Mahesh Shanmugam is there. He's already entering in for the next session. He has made 10 commandments for vitreoretinal surgeons. So we should try and make 10 commandments in endophthalmitis, 10 valid points, try and distill, and we can discuss in some other forum. The 2 points I would like to end by saying that, we should not believe that it won't happen to us. The only groups of people for whom the endophthalmitis may not occur is for those who don't operate enough, or those who are lying. So he who never climbed never fell. So whoever climbs, so
therefore my first slide said the pain of all this is realized for an operating surgeon only. You see, people who operate, they only realize all this. So I think with this, we'll thank all the speakers. We'll thank Coscon, we'll thank Elon, and we'll thank DC and Matthew for making useful contribution. And maybe we'll meet physically some other day and try to pin this 10 commandments which KSK was saying, and maybe revise the AS guidelines also. So I think with this we conclude in time and hand it over to the next set.
Thanks everybody.
Thanks, Kumar and Matthew.
Thank you very much. Thank you, sir.
Thanks,
Thank you.
Thank you, sir.
Thanks a lot.
Thank you, sir.